All right, I'm joined by Dr. Lesnick today. We're going to use our task trainer here to go over peritonsillar abscess drainage.
So when you have someone who's concerned for a peritonsillar abscess, we like to use imaging to confirm the diagnosis, whether that be ultrasound or CT. Once you have confirmed the diagnosis, that'll also give you the information on how much distance you have before you should reach the pocket of pus, as well as how much distance you have between the pus and the carotid artery, which we do not want to hit. We like to then proceed with a topical anesthetic such as lidocaine spray to the back of the throat, as well as using some injection of lidocaine with epinephrine using a 27 gauge needle.
So as Dr. Lesnick showed there, we like to use a 10 cc syringe followed by a lumbar puncture needle where we can cut a guard to make sure that this needle does not puncture too deep. For the 27 gauge, we use that one first to anesthetize the patient, and then we follow that up with an 18 gauge lumbar puncture needle. And this just allows for the needle to be more in the mouth as opposed to the syringe, which takes up more space. So we like to have the patient that is upright with their head back up against usually a hospital bed. Want to make sure that we have suction available there. And we use a laryngoscope blade. Typically, I like to have the patient hold the laryngoscope blade, although sometimes people like to hold that themselves. We'll go ahead and hold the laryngoscope this way, putting the blade into the mouth, and then coming down in order to get the correct visualization. So now that we're looking in the back of the oropharynx here, you can see the uvula is midline. You're seeing some displacement from the patient's right side here. This line is the palatoglossal fold, which is a key landmark when you're doing this procedure. You always want to start superior lateral to that palatoglossal fold, and that'll be your first landmark which you go for. If you miss there, you're going to come just a little bit down and out from there, and then your third spot will be a little bit further down and out from your second spot. So taking the needle, I'm going to go ahead and advance to that superior lateral position. I'm going to aspirate as I advance. And typically, you're looking to get out about 1 cc of pus. Sometimes really large ones will be several cc's, but it's not uncommon to not get out a whole lot. So you can see here, I'm aspirating back, getting purulent drainage. So this would be a successful drainage. We'll go ahead and come out now at this point. And as we pull back, want that guard to come with it. Then we'll make sure that our patient is able to handle their oral secretions, make sure their pain is well controlled, there's not any airway concerns, and then we'll discharge that patient on antibiotics with strict return precautions.